The limit for me is, can I handle the soft tissue? And of course, this also relates to the implant position and to the neighboring teeth. If I lost attachment on the neighboring teeth, I guess, Sasha, you will agree, your results will be difficult to achieve. If you have the attachment and a non-infected soft tissue, then you can handle those cases. So we have to swim around those issues. Infection, is the soft tissue manageable for immediate? I mean, I can clean it and I have to augment simultaneously and to cover it and to handle the soft tissue. And this depends on the implant position, attachment of the neighboring teeth, and the amount of infection. That would be an approach of an answer. What do you say?
And Carlo, if you don't have infection, you don't have perimplantitis, let's go to the other topic.
If we don't have infection, we check the main topic is related to the position of the implant. If we have the very worst angulation of the implant, we have to remove the implant. But if we have an angulation between the main axis of the implant and the main axis of the prosthetic restoration less than 45 degree, we can try to put
less than 35.
45 degree. We can treat we can try to save the implant, and we can use a welded abutment to move the hole of the implant more coronal.
So it's 45
but in any
degrees.
case, we don't have any kind of infection, and the prosthetic, we can do the prosthetic procedures. Are the two very important topics.
But do you consider if the implant surface, the buccal implant surface, is in the bone 100% or is outside the bone, if there is a recession of the...
Yes, but in some cases, the very important problem is to treat the implant without infection. In some cases, we have some part of the implant out of the bone, and Giovanni treat the surface of the implant and then cover with the soft tissue.
Okay.
This is the traditional process. But if we have infection, we remove the implant.
Okay. And Sasha?
Maybe there is a question from Sasha, for Sasha. Can we ask Sasha?
Yeah. What is your position on this?
You know, like my position is that it's always better to remove the implant.
I think we are coming from the same school.
But you know, I have to, of course, be also very patient focused. It's like there's very few patients who, when you give them the choice of like, hey, I can try to improve this a little bit, and I don't know exactly how long it's going to last. But it's one procedure, short procedure, and you know, we can wait and monitor it. It's a lot easier for many patients to digest than to go to the treatment like I just showed you, which is like a 1 to 2 year treatment. But no question that if it's a minor problem, I think you can try to do and repair the site with no guarantee to the patient. But if it's a big problem and a big defect with infection and bone loss and soft tissue loss, I mean, I tell patients, you know, it's inevitable. If you're not going to do it now, we're going to do it a little bit later.
So I have a comment, which
yes.
is, so my position is exactly like yours, but I think that now knowing what Giovanni Zucchelli has done and Carlo, I'm changing a little bit, but not so much, a little bit my mind. I think we have a kind of a psychological problem. So when we see a patient with an implant in such a bad position, I think we immediately hate that implant. So you want to remove as soon as possible, start again and put a good one. So I think this is a definitive kind of treatment. But on the other hand, I have done very few cases in which the implant was not so bad, and the treatment was, less less cost for the patient, shorter, and less aggressive. So I think that in some cases we should start to consider those techniques because what we have seen are wonderful results.
I do have a question to Giovanni and to Carlo. When we cover recession in teeth, and we know they heal with a little bit new attachment, but more or less with a long epithelial attachment, which we can maintain stable over time. But what happens on an implant? I reviewed all the literature and looked up all the histology I had access to, but I never saw long epithelial attachment on an implant. So so my question would be, if we cover the exposed surfaces, the abutment or implant with soft tissue, how will that be stable over time, and which kind of attachment do we have? Do we have a pocketing then, and on long term a risk? What is your opinion to that? Because I really don't know histology about the healing.
Okay, I don't have an experience on histology because I'm prosthodontist, but we have a very, very big experience with this kind of implant. And in general, Giovanni increased the amount of the soft tissue, and the soft tissue are stable and after or in this situation. I don't know exactly which is the histologic situation, but from prosthetic point of view, the tissue are very stable. It's very, very easy for the patient to clean the soft tissue. The main problem from prosthetic point of view is the cemented crown and not a screwed crown. This is a very, very big difference between when we put an implant and we study very well the position of the implant, or when we have to restore and malpositioned implant. This is, from prosthetic point of view, the very, very big difference.
Maybe he was asking for the long-term success in terms of probing depth.
Yes. We have not long-term control on this clinical case, because we start with a welded abutment in 5 years ago, and the old case that we treated in the last 5 years have, but our success have a clinical success, but we check every 6 months the patient and clean.
So
and
the maintenance protocol is very...
protocol are very, very important. Yes, right.
There is a question from Sasha.
Okay.
Sasha, you've shown your beautiful established protocol over the years. Nowadays, what is your opinion on the use of PRF technology or bone morphogenetic proteins? Which is the US perspective on this?
Well, I don't want to represent the US perspective because I live in Los Angeles. Very different. But thank you for the question, and good to see you again. Well, I think the main thing is that this whole growth factor area, of course, has been now researched and looked at for probably about 20 years now. And BMP is still the leader in real osteoinduction. So that's kind of its own particular treatment. So that could be seen as an alternative to guided bone regeneration. But it's really not been has not taken off in the US in periodontal practices. It's maybe used in a little bit of oral surgical practices, just because the cost is too high for dentistry. I've treated a good number of patients, 100 plus patients, and I'm happy with the results. It's just like, it's too difficult really for patients to accept this. So I use it just in extreme cases, or older patients, or patients that have really multiple surgeries. All the other growth factors, you know, they're all like pretty much similar. You know, they're all like just sitting there in what I call a wound healing accelerators. So if you want to use PRF, you can. There's U.S. practices who use that. Emdogain, of course, is very popular, and that has some good soft tissue augmentative results. And the last one, which is like PDGF or GEM21, is still used mainly in periodontal offices, but nobody really is looking at them as a bone regenerator. So most people are just looking at them as wound healing accelerators, and which can help, of course, patients to have a quicker incision closure. But it's not really something which has been established now in the U.S. as a must in combos. So it's more used per case, per indication.
Great.
And Marcus, with your technique to treat periimplantitis in general, not only the aesthetic areas, what is the follow-up of the patient? I mean, how do you follow the patient post-surgically? What we have seen here in a study we are doing in Italy in the Italian Academy of Osseointegration is that the 3 months after the surgery or the treatment are critical, are crucial for the success of the therapy. So do you see the patients so frequently in the next month or next 3 months? And what is the long-term follow-up schedule of these patients?
Yeah, it depends on the case and depends on the patient. I mean, the primary aim is to achieve a complete reosseointegration. And of course, I don't believe that bacteria are the only etiologic factor for